Welcome to another episode of The Breakdown. I got to get the date on this one out front, the date that we're recording it, because it's going to be a little bit later that it comes up. And we could not have timed this pre scheduled interview better given current events. We're recording this on April 8th, 2025, which is, in fact, a day after April 7th. 2025. The reason why I'm highlighting these dates will become very clear as we get into the conversation. Alberta, Alberta, has been making some moves towards uh, chartered surgical facilities. And it's a broad conversation. At points, it could be considered a complex conversation for a whole long list of reasons, some of which we will not get into today. But there's some very real concerns about the effectiveness of chartered surgical facilities. And to get into that a little bit more, we're very excited to welcome to the show today somebody who has been taking a look at the effectiveness of chartered surgical facilities, particularly in Alberta, for a little bit of time now. Very excited to welcome to the program Andrew Longhurst. Andrew, thank you so much for joining us today.
Hey, great to be with you, Nate.
So, to start with, before we get into the many, many things that we're going to get into today, uh, you are a PhD candidate out of Simon Fraser University, and you have a wild specialty. The looking at the Simon Fraser University human geography. I have so many questions. Well, I'm going to ask you what human geography is, but before we get there, who is Andrew Longhurst and why do you care being in Simon Fraser University, which is, unless I'm mistaken, is still in BC? Why do you care about what's going on in chartered surgical facilities here in Alberta?
Yeah, fair question. Fair to say, I came to health policy in somewhat of a roundabout way. I got involved in doing work with the Canadian Centre for Policy Alternatives here in BC at the BC office, looking at how we reduce surgical wait times. It's a big issue. It affects a lot of people. It's a very much a political issue. It remains kind of one of the thorniest issues pretty much election after election. So there's a lot of, I think, importance placed on it, and rightly so. So I think, it's going on about a decade when I worked with a number of other colleagues, and we published a report on what was being proposed in BC at the time, which is allowing overnight stays to be performed in private for-profit facilities. This was in 2015. The BC Liberal government of the time was floating a trial balloon and suggesting that this is the direction they wanted to go. And we wanted to respond to that proposal. And we looked at the research literature. We looked at the experience in BC, and we had a large focus on a jurisdiction that has actually been one of the most committed to reducing wait times and improving patient care, and that's actually Scotland, the National Health Service in Scotland, not to be confused with NHS in England. Separate countries, very different politics at play. And we did a really detailed study and look at the experience and how that jurisdiction had effectively reduced wait time. So got quite engaged in this topic in my work early on. And at the time, I think I was recently minted with a master's and in human geography. And geography is interesting because it's one of these disciplines that is interested in so many different things. And a significant strand within political and economic geography is the role of policy and politics and the movement of policy ideas from place to place and their ideological underpinnings. So it's very interesting for me conceptually to think about how Alberta really initiated the inception of the ASI from former Premier Jason Kenney was based on the quote unquote successful experience with the Saskatchewan Surgical Initiative. And so this policy idea has really kind of been on the move. And so, as a geographer, as somebody interested in the relationship between space, the movement of ideas from place to place, and the people that move them. There's just from an academic perspective, quite interesting in how some ideas have legs and some don't. And in the case of for-profit surgical delivery and surgical privatization, that there are a lot of people that seek to benefit financially from a policy approach that enriches some and really, at the end of the day, I think takes from a lot of uh, the benefits and the public assets of what we have collectively as a society paid for. So the fact that we train our workforce through public institutions, all of the benefits of what we do collectively as a society, some of those benefits are being transferred in the form of surgical privatization. Those those resources, those investments, and those at the end of the day, those public dollars paying for those surgeries moving towards private investor-owned facilities who are doing quite well at the end of the day. And that's, I think, the big concern with that transfer of public wealth to for-profit interests in the province of Alberta. So that's a little bit about where I come at it. And over the years, I've done a lot of research on various parts of the health system, including primary care, seniors care, privatization within in seniors care, which is ongoing and a significant issue as well, and also a lot of the workforce issues that are fundamental in terms of understanding how we improve healthcare for everyone. If we don't understand the role of the workforce and the very dedicated folks who are on the front lines delivering care.
Gave me a lot to unpack there. Um, so I want to start. I mean, first of all, I just want to clarify. You used an acronym there, and then you kind of implied what it was, but I want to make sure everybody is clear. ASI, unless I'm mistaken, stands for Alberta Surgical Initiative.
Correct.
Okay, cool. And when we're talking about, if we can just talk about what a chartered surgical facility is for a second, just to kind of set the groundwork, and then I'll get into the meat and potatoes of things. My understanding of a chartered surgical facility is it is a private company that is for profit and they offer services, they replicate services that are in the presumably in the public healthcare system. This is being done in an effort. The idea, he said cautiously behind it, is that if we expand the number of places that are doing the things, we can get more people in to do the things. Am I doing okay so far?
Great.
Okay. There's some problems though, and you've been following these problems for a little bit of time now. Back in, I want to make sure I get the date right, 2023, you released a paper called "Failing to Deliver," which sounds great. I mean, that sounds things are fantastic. Could you go into what failing to deliver was and what made you write it?
Yeah. So that really a first evaluation of the ASI Alberta Surgical Initiative that was looking at the first 3 years of the experience in Alberta with surgical privatization. And to be fair, this is not a new phenomenon. This dates back to the Ralph Klein era. There have been for-profit facilities, out-of-hospital facilities delivering minor surgical procedures and other minor procedures that don't require an overnight stay. These are the lowest complexity procedures with stable patients. So it has a longer history, certainly, and dating back to the early mid 2000s. Health Resource Center in Calgary was a for-profit facility. It had to be bailed out by Alberta Health Services. So there's a long history of these sort of misadventures in Alberta with for-profit surgical initiatives. But what I really wanted to do with that 2023 report is, okay, let's assess what is actually going on with this initiative. It's been a very high-profile initiative of the Alberta government at the time under Jason Kenney. It was intended to work down the surgical backlog. It was initiated before the pandemic began, but then the argument became like this is going to be really, key to our success moving forward and coming out of the pandemic surgical backlog. So that report looked at the claims that the government made, and those claims or objectives of the ASI was that it would increase total surgical capacity, it would reduce wait times, and it would do so in a way that better meets the needs of patients in Alberta. And so on the issue of did it increase total surgical capacity, what the data showed is looking at surgical volumes overall, they actually declined in the province over those first 3 years, and really the growth in the for-profit facilities was where they were. Where the focus was and where the increase in volumes was coming from at the expense of public hospitals. So when we then looked at the wait time performance across priority procedure areas, these are tracked by the Canadian Institute for Health Information. All provinces report their data to the Canadian Institute for Health Information. It goes by the acronym CIHI. And CIHI makes that data publicly available, which is great because then you can do provincial comparisons to see how different provinces are performing. And across the priority procedure areas, namely orthopedics, Alberta was doing markedly worse than other provinces, and worse than before the ASI was initiated. So now, one of the arguments that came out at the time as well, the pandemic still, we're still in the thick of the pandemic. Things are very challenging. There is a kernel of truth to that. But what I would say to that is when I looked at the investment in other provinces around operating room staffing and investment in public operating rooms, Alberta was and continues to be a real outlier in its really refusal to make those investments in public operating rooms and public sector capacity. And so when we look at BC as an example, side by side, there was a big focus on investment on public ORs and performing more surgeries in those facilities. So all in all, did it meet its stated objectives based on the 2023 evaluation? No, it didn't. And in fact, we saw total surgical activity in the province decline.
Now, there were a couple other things that you highlighted in that report that I just want to kind of flesh out before we move on to the most recent report and then yesterday. Um, the things that you highlighted, the one of them was a higher cost of for-profit surgical delivery. So the idea that seems to be pitched by advocates of chartered surgical facilities or profit-driven surgical facilities. I mean, the math to me is just like really simple, but I'm not that bright. Um, the idea is, well, hey, these private corporations, they want to make sure they're making the most amount of money, so they're going to find all of the efficiencies. And there's no question that there's some private organizations that are very, very good at finding an efficiency. But at the end of the day, a private corporation is also responsible to its shareholders, to its owners, and then they exist not for the greater good of the public, but to make the monies. So can you talk a little bit about what the higher cost, like they say it will be cheaper and better and wonderful, but it costs more?
Yeah. So since the 2023 report came out and the most recent report that I published with the Parkland Institute in March of this year, uh, found and largely based on the revelations that came out in the Globe and Mail, we know that these publicly funded for-profit surgeries are significantly more expensive than those performed in public hospitals. And this is based on internal costing that Alberta Health Services conducted, and it found that for-profit facilities are, up to 2 times more expensive than having those same procedures performed in public hospitals. And this is not, it is shocking, I think, in the sense that, why would we then be using these for-profit facilities? But since, these revelations and since the 2023 report that I did, we've had more and more examples of government paying a premium to for-profit investor-owned facilities to deliver the very same procedures that can be performed more cost-effectively in public operating rooms. In Ontario, we found in 20 yeah, it was in 2023, end of 2023, revelation that one of the largest chain provider of out of hospital surgical care was receiving a premium to perform the same procedures that are more cost effective if they're performed in public hospitals. We also had similar revelations that came out in Quebec, where they were paying significantly more for the privilege of having investors build facilities and have them performed in private for-profit operating rooms. And we've also seen examples in diagnostics as well, where we have evidence to suggest the same. So, we see a picture emerge quite clearly that this is not rooted in good economics. The public is paying a premium, public tax dollars to pay these facilities to build parallel operating rooms when we have public operating rooms that have already been paid for in our public hospitals. It's infrastructure that's already existing, and yet they're not being funded and staffed up to use that existing infrastructure. That's a huge opportunity cost to not use that existing infrastructure with the workforce that's already in place. But yet we see, like Alberta, provincial governments continuing to pursue this. So it is, I think, very clear that it's no longer being pursued for economic reasons. It's much more ideologically motivated.
Okay. One of the other things that you talk about in the first report, 2023 report, is the increased public sector staffing shortages and destabilized public hospitals. And I'm going to paraphrase what you wrote in there a little bit, but if I'm getting the idea right, there is finite resources to do the things. And when I say finite resources, I mean there's limited number of people who can do hip replacements, knee things, shoulder stuffs, all of that. Um, and because the private system, the chartered surgical facilities, they're able to kind of, unless I'm mistaken, they're able to kind of cherry pick which patients they take. So if somebody's at a high risk of complications for surgeries, then the chartered surgical facility can go, no, 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 we want the easy ones. And what that means is that the work that's being done in chartered surgical facilities is among those surgeries the easiest. So they're taking the easiest knee replacements, they're taking the easiest hip replacements. And that creates a very tempting work environment for people who are feeling burnt out, for people who are feeling tired. But there's still only X number of people who can do those surgeries, who can support the physicians doing those surgeries. And so it seems like what you talked about in there is the private for-profit system actually leeches off of the public system resources in the way of the skilled people who can do the things. And that leaves the public system even more weakened. Am I getting that right?
Yeah, you got it. So, I mean, that's what we've seen. We're seeing that we saw that play out based on the data in the 2023 report, and we've seen that now with the updated 2025 report looking at the 5 years of the ASI. And you know, it's interesting because to me, it's not a difficult concept to wrap your head around. Anesthetists, operating room nurses, surgeons, technologists, support staff, all of these folks can't be in two places at once. If they are working in chartered surgical facilities, they're not available to be working in public hospitals. And what we're seeing, and I think is playing out quite clearly in Alberta, is the preference, as you say, to be having predictable daytime hours, not having on-call responsibilities, not having to necessarily show up in the middle of the night because you have an emergency surgery that needs to be done. All of these things, to some degree, I can't fault, people for wanting that. But you can't run a health system based on that. or at least you need to build in some guardrails to ensure that you don't entirely see your workforce shift to focusing on the least complex surgeries where there's the highest profit margin. And that's what's happened. And this is not just an Alberta thing, it's not just a Canadian thing. We have a body of evidence coming out of England, which is a jurisdiction that has been down this road for much longer with private for-profit facilities delivering outsourced surgeries. The British Medical Association has raised alarm for many years about what's called this distorted case mix in hospitals. That means that the workload and the complexity of the work becomes so demanding in public hospitals, it is a recipe to burn the workforce out and have them exit. And that's the risk, and that's what's happening in Alberta, and much like what I think we're going to see in Ontario, as a province that has committed to go down this very same road, is you are going to have that distorted case mix where everything complex is ending up in public hospitals. The per unit cost and staffing requirements in your public operating rooms increases dramatically. And meanwhile, all the easy stuff is being done in for-profit facilities where you're doing daytime hours. And one of the things that we're seeing is the government initiated the ASI without any safeguards in place, saying, as an anesthetist, you still need to have responsibilities uh, to emergency surgeries and after hours in public hospitals. None of these safeguards were put in place. So it is what we're seeing. And you look at the volumes in terms of what's happening, there is no question that, of course, we're seeing a big focus on things like cataracts, on fairly low complexity orthopedic procedures. And again, keep in mind, these are patients that are stable. They're referred to as ASA 1 or 2. They are not medically complex. They are not at risk of complications in the operating room. So you're also starting to see these inequities play out. And we can talk more about this, but there's some very interesting research that just came out of Ontario last year, looking at the fact that the healthier and the wealthier are increasingly having their procedures done in for-profit facilities. They use the example of cataracts because when we look at the health of the population, there are gradients in health in terms of your health status, and those that are higher income, higher socioeconomic status are generally the healthiest in the population. And that's a large body of decades of research that we know this. And so we are creating this inequity within who gets access, even within a publicly funded system, of who's being prioritized for their surgical care. And the example of cancer surgeries, where median wait times are longer across the board after 5 years of the Alberta Surgical Initiative, point us in terms of what the evidence is showing of why this focus on the least complex surgeries with the healthiest patients is to the detriment of patients who have more complex health needs, who tend to be lower income, and who have a need for longer stays. Now, cancer doesn't discriminate based on your income status, but again, this is very concerning in terms of what we're seeing playing out in terms of that divide.
I got a couple questions because I'm a curious bloke. Um, do you know, like, if I'm a nurse or a surgeon or an anesthesiologist, do I get paid the same in the public system as if I went to go work for a chartered surgical facility? Is the pay rates all static, or can I come with more money doing chartered stuff?
Yeah, that's a great question. Maybe I'll take a step back and say, so the way that chartered surgical facilities and most for-profit facilities are paid is they negotiate per unit prices or per surgery, per procedure prices, I should say, with government or with their funder. So, a public health authority or the provincial government. And in Alberta, this is, the center of many the government trying to say it's just AHS, but then the public record showing quite definitively, no, it's actually the provincial government that's intervening and having full control over contract negotiations and the contracted prices that these facilities are receiving. That's typically referred to as the facility fee. So that's all of the non-physician staffing and overhead and everything that is the cost of performing that in that private facility, as well as, building in the profit margin. On top of that, though, to answer your question, so physicians and surgeons separately bill their professional fees to the Alberta Healthcare Insurance Plan, the public insurance plan. And that rate is the same whether they're delivering a surgery in a public hospital or a private for-profit facility. Now, the thing we don't know, because the business operations of these for-profit facilities are completely shrouded in secrecy. We don't know how they do their business. We don't know what their contractual relationships are with their surgeons. We know that some of them are investors in the surgeon, but we don't know what their finances look like and how money is moved around and what those contractual relationships are like. So it's very possible that some of those facilities also provide an additional payment to the surgeons to perform that surgery in their facility. That's something that's not prohibited, it's not legislated, it's not regulated, it's not transparent. We don't know. And a lot of these very concerns about the lack of transparency about the relationships between surgeons and physicians working in those private facilities and the agreements they make came to light in the Cambie surgery litigation here in British Columbia, where a long-standing proponent of privatized medicine and the CEO of Cambie Surgeries Center, a long-standing private surgery clinic here in Vancouver, that constitutional challenge, which has now ended, and they were unsuccessful in their claims, but many of those issues that I mentioned around the uncertainty and the lack of transparency around what are the incentives that are being offered to surgeons and physicians to do their surgeries and do their work in private for-profit facilities, it's completely a black box in this country. And when we're talking about public dollars and the movement of scarce health human resources, there needs to be transparency in terms of what those relationships are. And I would take the example of some other jurisdictions. There are lots of problems with England. There's no question about that in terms of healthcare delivery. But has at least been more of an effort made to create a firewall between physicians and surgeons who decide and elect to work in a private for-profit system and those who do publicly funded, publicly delivered care. And right now in Alberta, there is a revolving door. And this is a huge problem for any ability to control costs for the public, to have certainty about what's actually happening in these centers. Do we know because we don't have access to their data? It's often the argument is this is proprietary. Well, it's actually patients. These are public patients at the end of the day. So there's a whole number of concerns about the environment that has been created in Alberta and what that means for having any accountability. The Premier likes to talk a lot about accountability, but we actually have no accountability with private for-profit facilities other than the contracts that get negotiated, which keep in mind are not fully transparent.
Negotiated, dictated by ministerial directive, potato. I love that you threw in the black box bit because one of the things that Danielle Smith has used to justify moving to this chartered surgical facility model is, well, Alberta Health Services has just been this black box of money where we can't see where the money's going, and you can, but she's moving it into these private facilities that are black boxes. I'm curious because, like, here's my thing, and I want to talk. We're going to talk about the April 7th big announcement. But like, if the appeal for physicians and staff, the biggest appeal is you get to work on the easiest cases, and you'll work the 9 to whatever's. You'll have that stability. You'll have that little break from the apocalypse. Why not just make those clinics inside of the existing public healthcare system. Like to me, it would make perfect sense to have like a 6 month rotation in the easy clinic, and then you go back to the general clinic, and then you don't have to have the profit piece. And we've heard lots of stories about oh, there's all these empty operating rooms. I mean, you referred to them yourself earlier. Wouldn't it be easier, more responsible, and cheaper, he said cautiously, with access to actual hospitals in support if you were to say like, hey, we're gonna do the easy clinic for a bit. We're gonna keep it in-house. And that way everybody gets to know where the money's going, how much is being paid. Is there any reason why we couldn't do something like that?
There's absolutely no reason other than the political will necessary to make that happen. And in fact, what we've seen, we have a number of examples across the country and internationally about taking advantage of sort of the factory model with these high volume, relatively low complexity procedures, doing them in environments within public or not-for-profit hospital or facility settings where you benefit from those efficiencies. We've seen examples here in British Columbia where you're also designating a couple ORs only to be performing these procedures. So you're not switching over your equipment. Everything is pretty stable in terms of benefiting from kind of this factory model. And that's kind of the scale that a lot of these for-profit centers work on. They're doing these low complexity routine procedures where they don't have to change the ORs. There's very little downtime. So those same efficiencies, there's absolutely no reason why those same approaches. And in fact, we've seen, like I said, a lot of the best work reducing wait times involves those operating room efficiencies and operationally making changes in your surgical programs to take advantage of those economies of scale. And there's other things that can be pursued that extend beyond just the operation and the operating room itself or the perioperative efficiencies, which is how do we actually manage our surgical wait list to be much more efficient? There's a body of research that comes out of mathematics called queuing theory. And what queuing theory tells us is having one queue or one line for a certain service rather than having hundreds of them is actually much more efficient because it equalizes the weights and at the end of the day reduces the weights rather than like lining up at the grocery store where everyone's waiting in a different line with varying weights funneling people through like the bank teller through one line and then distributing them to the first available surgeon is what high performing health systems do. And I was in a room with a group of physicians and surgeons, probably about 200 of them in Alberta. And I asked, how many of you, if you're in a surgical specialty, how many of you used what's called a central intake and first available surgeon model? And I had one surgeon within that room of about 200 physicians and surgeons raise their hand to say yes. So this is a very basic efficiency and innovation that the Alberta government is not taking up. They're clearly focusing on surgical privatization when we have a large body of evidence internationally saying a centralized intake and first available model where you're also working with a broader team of providers in the area of orthopedics like advanced practice physiotherapists who can help do the rapid assessment and triage. A lot of consults, for example, for orthopedic surgeons, about 50% of those don't actually go on to surgery at that time. Many of those can be more rapidly assessed by a specially trained physiotherapist. And this has been done safely and effectively in lots of different jurisdictions. But it just shows you there is no political will right now from this government to pursue the evidence, to use what is effective, and where there is consensus about what actually gets patients their surgeries more quickly, more safely, and more effectively, and with higher satisfaction. And that's what a lot of these team-based models show, is when you actually distribute the work, you're benefiting from the unique expertise of a physio who can actually help you support you in your condition. You maybe meet with a dietitian so that you're better prepared come your surgery to have a good outcome. You're doing weight reduction. So there's all kinds of benefits to working with a team and working in team-based models where you're streamlining and taking more active management of the surgical wait lists across different specialties. But like I said, all of that is languishing uh, because this government has decided that for-profit surgeries is where we want to put the entire focus.
I want to ask about one other thing before I move on to the big announcement. Um, as I'm solving healthcare. But one of the other things that we have heard, and I'm curious if any of the stuff that you've looked at covers this off. One of the other things that's been talked about anecdotally in the media ecosystem is there are reports that the complication rate and the infection rates coming out of some chartered surgical facilities are significantly higher than what we would see in the public system. And the rub there is that they don't deal with those. So if you go to, and please correct me if I'm wrong, but my understanding is if you go to a chartered surgical facility here in Alberta and you get an infection, their response is like, "Hey, sorry, Peter Lougheed's over there." And you then get punted to the public system to deal with the problems that that chartered surgical facility unintentionally created. Am I getting that wrong? Do you have any information on what those rates are?
So that's a great question. And I anecdotally am hearing that as well. I'm also hearing in Alberta that there has been resistance and a very clear directive to not collect infection and complications data in chartered surgical facilities. This is a huge concern because we know based on the evidence internationally, and again, I look to England, where we have documented evidence of hundreds and hundreds of millions of pounds in costs being downloaded onto public hospitals for complications that came from procedures that were performed in for-profit facilities. This is not a new issue, but the fact is, it seems that the Alberta government is so intent on demonstrating that this approach is working that they are likely to do anything they can to protect this information from coming out or prevent it from coming out, I should say. So I think the concern here is complications and infection rates, all of this information, we need to be moving to a quality improvement approach. And this is not just, I'm not saying that it should just be for private for-profit facilities across the board. Having data that is publicly available, it's transparent, and that allows providers and organizations to do their best work and improve and understand where there are lapses and where there are quality concerns. It's not necessarily about naming and blaming, but I think there is in a sector that is profit motivated, we would be entirely naive to think that this isn't an important part of quality assurance and patient safety. And we have seen in Ontario, it took reporting, investigative reporting by the Toronto Star. This was a number of years ago, that out of hospital settings, there were issues around bloodborne infections, HIV, hepatitis. These issues and the lapses around safety only came to light because of that investigative reporting. And the outcome of that was a much stronger regulatory approach to understanding what's happening in those private businesses, essentially. Again, we don't know what's happening in for-profit facilities in Alberta. And what I am hearing is that there is a directive to not collect the data. And I think the issue is we need to understand how many folks are showing up in public hospitals with complications, with infections, with washouts, to understand, the costs borne by hospitals are significant, but how much of that cost is actually a reflection of complications and infections coming out of for-profit facilities? We don't know. What I'm hearing is a concern.
So Would I be safe to say if we were to have the mechanisms to have these easy clinics, I'm just going to call them easy clinics because it's a lazy name, inside of the public system, would it be a safe hypothesis that you might see lower infection rates? You might see better satisfaction with the employees, and all of that would come at a cost that doesn't have to include a profit margin. But is that a safe?
That's a safe bet, yes.
Okay. We solved healthcare today on the
There
breakdown.
you go.
Fantastic. Um, there's and this gets to the piece that is yesterday because it seems to me if there was even just a modicum of political will, there are ways to um, solve or at least address some of the concerns that people have about surgical wait times and all of those things within a system that does not have that profit factor built into it. Um, I mean, there's options that don't have to make other people very, very wealthy, and that can still take care of the staff, and that can still make sure the surgeries get done, and that can still make sure that if somebody has complications, they don't have to be driven across town; they could be wheeled across a hallway. Um, all of that being said, the premier made this fascinating announcement yesterday, and I mean, I'm gonna say there was one clip in particular that I mean, I really liked the Rick Bell bit. I had a lot of fun with that. But the one clip in particular that really struck me was when Graham Thompson asked Danielle Smith, like, okay, so it's identified that having chartered for-profit surgical facilities pulls resources out of the public healthcare system. And now you're saying that if those public healthcare operating rooms aren't being used efficiently, you might say, and now the chartered facilities gets to operate inside of the public healthcare system, saving themselves all of the infrastructure costs, but still making all of the monies. And Danielle and Graham Thompson was like, "Is that what you're saying here?" And Danielle Smith's response was, "Mm-hmm," which was bonkers to me on so many levels. But what do you make of yesterday's announcement? And as a follow up, um, what do you think Albertans should make of yesterday's announcement?
Yeah, there are lots of issues with what was announced. So activity-based funding, I'll just start with activity-based funding has been used in lots of different jurisdictions. It's a volume-based payment model for paying for episodes of care. It's often used in a lot of jurisdictions fairly narrowly for a limited set of procedures or healthcare interventions. When you can see a clear beginning and end to that care or intervention. So cataracts would be a fairly obvious example. It's fairly easy to say when does the surgery start and when does it end? For things like, and this is one of the questions, the press release seemed to suggest that the direction of travel is that everything in hospitals is going to be activity-based funding. It sounds like starting with some, they're going to run a pilot for some procedures. They want that to be up and running by 2026. But it's unclear. It sounds like, everything. So first of all, activity-based funding is completely inappropriate for many things. And this is what the literature says and what we've seen in a lot of jurisdictions, where it is rewarding volume that there are a number of perverse incentives, it really depends on how it's designed. But I think what we generally see is because it rewards and incentivizes volumes of high volume to generate revenue, because this is the idea here is the more volume of certain stuff you perform with a cost attached to it, the more revenue you generate. But it doesn't account for, or it tends to incentivize short length of stay and getting rid of patients as quickly as you can. So the concern that I have based on everything that we've seen in terms of how this government operates and what it's doing to healthcare is the design of an activity-based funding model in the province of Alberta, and because there's a clear bias from this government on investor-driven healthcare, private is great. Everything private is better than public. And that's not what the evidence says, but that's what the premier says. And so there's an inherent bias moving in this direction where a funding model, an activity-based funding model, will will benefit those private for-profit groups and facilities where they're focused on the low complexity, high volume procedures that have the highest profit margins. And those, in some ways, are what we're already seeing. We're already seeing what this looks like. We're seeing that at the expense of cancer surgeries, the focus is on the low complexity, high return procedures in chartered surgical facilities. So I see it as a continuation, but I also see it as an acceleration of what we're already seeing, which is creating those perverse incentives to just focus on what's easy and fast, and then be able to say, well, look, hospitals are just so expensive and costly. And of course, they're dealing with the most complex procedures and the most medically complex patients who often have longer lengths of stay in inpatient beds. So I have so many concerns about this direction. And I also think, having watched the premier's video that was part of the press release or the announcement, there is what I call the government is guilty of drive-by comparative health policy, which is when they completely decontextualize what's happening in those jurisdictions who have used activity-based funding. So the premier has used these examples of Northern Europe and Scandinavia in particular without any reference to the fact, well, first of all, these are jurisdictions that spend a higher share of public funding on public health care, and you also have a much, much stronger system of home and community care and post-acute care to support post-surgical patients. So a lot of, keeping in mind, activity-based funding came out of the US at a time when they were trying to control Medicaid, so the public portion of health spending in the US, they were trying to rapidly control Medicaid expenditure. And much of that had to do in the US with the growth and explosion of for-profit hospital chains. So this model was intended to create certainty and contain costs within that system. Now, the unintended consequences, and now 30, 40 years later, the experience with activity-based funding internationally for hospital care has shown that it has a tendency actually to increase healthcare expenditure. Keep in mind, that's the exact opposite objective of what the premier has claimed, because it incentivizes more activity and not activity of necessarily the right things. Like I said, you're finding the things that have the lowest marginal cost that are the most profitable. What can you do that has the least overhead and staffing requirements that generates revenue for your organization or your business? And those are the areas of focus. So it tends to increase spending, not decrease it. And the global budget is, it's interesting that Premier Smith is making global budgeting such a target because the global budget actually creates certainty in a way that activity-based funding doesn't. So again, all of these claims that are being made, the evidence shows the opposite. We also see, again, this perverse incentive to get rid of patients as quickly as you can without the follow-up care necessary or the length of stay in inpatient care that may be necessary for more medically complex patients and patients undergoing more complex procedures. So that sort of, I think, the main concern is an acceleration of what we're already seeing playing out. And again, that movement of the workforce into doing more of the low complexity. And then I think the point that you made, or the comment that came out about public hospitals being encouraged or having to lend out their public operating rooms to groups of private surgeons and for-profit corporations to perform procedures within public assets. This is very concerning because it's essentially public assets paid for by taxpayers, the public, in the service of private profits. And that is increasingly, I think, the direction of travel that we're seeing, not just with surgical care, but also with the movement towards recovery-based substance use services that many of them have no shred of evidence behind them, but are backed by investors and for-profit corporations who have a lot at stake in terms of making money off of public dollars. And not unlike the US, where the Alberta Premier likes to spend time, we're seeing a movement in that direction of the public purse being in service of enriching private individuals.
Which, I mean, you walked me right up to my next question, because it seems to me, and I'd love to get your take on this. It seems to me that what we're fundamentally talking about is priorities. And the question that I would ask the premier, were she ever to take one of my questions, she will not, is what is the priority here? Because if the priority is patient care, adding the layer of, and somebody's got to make profit, like there's nobody in Alberta Health Services who's making profit. AHS as an organization doesn't profit off of the things that they do. Um, if the priority is patient care, there should not be a profit function. If we're introducing a profit function or expanding an existing baseline for a profit function, that says to me that the priority is not the patient care. The patient care is a means by which to access the profit, because the profit is the goal. And so I am having a very difficult time wrapping my head around how the Alberta healthcare system is not being restructured in a way that is not about patient care, but it's about opening up the public purse so that people can make profit. Am I getting it wrong?
No, I think this is exactly what's happening. And I think this is a government that has been clear. It's taking its cues from organizations like the Fraser Institute, the Montreal Economic Institute, right-wing think tanks, and others who draw their policy ideas from the United States. They have an affinity for private healthcare insurance. There is a desire to increase the role of investor-owned facilities. And what we are seeing, and my research has demonstrated this, these are the profit motivation and the desire to maximize revenue from various sources means that we have for-profit facilities across this country who have been engaged in both taking payment through public contracts, through outsourcing, and then on top of that, and contrary to provincial laws and the Canada Health Act, also demanding payment privately, individually from patients. And so, we're seeing kind of the complete erosion of any commitment to public health care being in the service of the public, being a government that is stewarding public dollars so that they are not bleeding into profits, which is happening across the board when we introduce investor-owned facilities. Seniors care, long-term care is a very telling example of a sector increasingly dominated by for-profit chains, where their business model is to extract public dollars and put them back into profits. So, this is inherent in the restructuring that's being facilitated, encouraged, and a lot of the policy ideas that they're drawing upon are intended to accelerate that process. And they're intended to demoralize at the same time public sector workers, leaving them with increasingly complex and precarious situations with patient populations that are facing multimorbidities. They're increasingly complex, and a narrow focus on parts of the system without thinking about the system as a whole. And so, a lot of the focus on this idea of moving towards activity-based funding, it's not to say there aren't places where it could work and it makes sense, but to not think about the fact that you don't actually have proper places to discharge a lot of patients safely. Like there's a whole part of the system that is completely underfunded, undeveloped, and unsupported by government, unlike a lot of the jurisdictions that the government is holding up and saying, well, in Sweden and Norway, they do this and they've had great results. It completely decontextualizes the realities and the fact that those systems are much better in a lot of ways, that Alberta is just fundamentally different and not set up to support people, but in turn, it's going to download costs onto patients and families to provide the care that they need if that care is not being provided for in hospital settings. This is a US style of healthcare that's being promoted where those costs get downloaded onto individuals. That's the direction of travel.
Couple of things that I want to pull out of what you talked about there, and I think one of the things that's important to highlight is I think we saw, correct me if I'm wrong, I think we saw during the pandemic the worst case scenario for what can happen when you outsource healthcare to private for-profit organizations, and I'm talking about the long-term care facilities in Quebec, because those were long-term care facilities that were supposed to take care of the elderly and the vulnerable. And because they figured out that you can buy things with money, there were some shortcuts that were taken. And because of those shortcuts, there were a boatload of seniors who died, arguably unnecessarily, or preventably is probably a better word. And that is what can happen when the profit motivator is introduced. And I would be willing to speculate that some of the problems that the provincial government is seeing in certain legal actions, uh, we take a look at, and I'm going to throw it's all alleged and hasn't been proven in a court of law right up front here. But if you take a look at some of the allegations that exist in the AHS CEO's lawsuit against Alberta Health Services and the provincial government, she's very, very clear. There were concerns that because there was a profit motivator, people were trying to influence and get close to the government, and the government then allegedly facilitated business deals, not because it was the best option, not because it was in the best interests of patients or the healthcare system, but because these are our friends, allegedly. All of this is unproven in a court of law. Rana, leave me alone. Um, but I think that the fact that those concerns are raised, I mean, it will be hopefully tested in a court of law. Hopefully, Albertans will have answers to these very, very, very important questions. But the fact that there's this new variable, which human frailty has demonstrated we're vulnerable to, is being actively introduced, seems to me to be a very dangerous choice. Uh,
Mhm.
and so, I guess my question after that little rant is, uh, am I wrong about the long-term care facilities and COVID and Quebec? And do you think that there is risk in injecting uh, this temptation into an environment that is already very, very fraught?
We have a body of evidence that came out of the COVID-19 experience in the early years of COVID-19, where we saw for-profit facilities generally perform much worse than public and not-for-profit facilities. And it is clear based on that that staffing levels and staffing mix are a structural determinant of care quality and also their ability to properly address infection control. And we've had the Royal Society of Canada put out a large report. We've had multiple reports published by academic journals looking at administrative data sets, large data sets, to demonstrate that generally, yes, for-profits are performing inferior compared to not-for-profit and publicly owned and operated. And largely, as I said, that has to do with staffing levels being lower and staffing mix being inferior in facilities where the business objective is profit making. And so we can't be surprised that corners are going to be cut. That's inherent in a profit motivated business. And staffing is the largest expenditure in healthcare. It's over 70% in most healthcare facilities and organizations. So it is clear that that's happening. And, I think just to add another layer to this, Nate, we are in a time of unchecked greed. I mean, we are in a moment in history where it, this idea that the public purse is entirely for the taking, our collective resources as a society that we have built up are something to be exploited by the wealthy. And I think this is what's happening in Alberta. Very clearly, this idea that the public goods, public assets, let's transfer ownership and take those public hospital assets away from AHS. And then, will we have any say in terms of how those public assets are then used to serve the benefit of private for-profit interests? I don't have any trust that we're going to have safeguards on that. It is, a time of incredible greed. I don't think there's any other way to put it. And we're seeing that in Canada, healthcare is one of the most protected parts of public spending. There's significant market opportunities in the language of a lot of investors, and they want action. Nate, I published a report in 2023 on Ontario hospital privatization and these same pressures that are happening in Ontario. And in that report, it includes several emails from a US healthcare investment advisory firm that was sniffing around for market intelligence about opportunities that they were no doubt going to use to advise their clients about investing in the Canadian healthcare market, as they put it. They see this as one of the last frontiers of making money. And so I think we have to be very live to the fact that this is seen as a way to extract wealth and benefit from assets and wealth creation that has been held publicly, collectively by all of us as citizens. And they want a piece of that. And it is at this point in time, really hasn't come up against a lot of barriers in Alberta as we're seeing. And those safeguards and guardrails are just not in place.
I'm going to go ahead and say the quiet part out loud because the subtext to all of this, this whole conversation, seems to be let's do the easy things so that we can make the most money. Um, and some people will be left behind. Some people will not get the care that they deserve. And by pursuing this model, the subtext to me seems to be, and we're okay with that. And that to me is perhaps the most alarming part of the direction that the Danielle Smith is so desperately pursuing within healthcare in Alberta is, there's clear shades of, well, everything that you do up to stage 4 cancer is under your control going on here. There is that cynical approach to people who are sick, who need help, and they didn't do enough. So we're going to take care of the people who are doing the right things. We're going to take care of the people who did do enough. And if you didn't, sucks to be you. You get the leftovers if you get anything. And that to me, please tell me I'm reading that wrong.
I don't think you're reading it wrong, and the evidence coming out of Ontario, I think even within a context of what is claimed to be publicly funded surgeries, we're seeing this divide taking shape, this two-tier system where faster access is available to those having their procedures done in the for-profit facilities. And as this study hypothesizes, these are also facilities where there may be either overt or more subtle coercion for patients to pay for an upgraded lens or something additional that then helps give them preferential access to their cataract surgery more quickly. This is quite a problem within cataracts where we see this type of upselling or coercion taking place. You don't need to pay out of pocket for cataract surgery. It's entirely publicly insured. But that divide, and then when we look at it based on socioeconomic status, those people being fast-tracked because they are willing to pay out of pocket, and they are being asked to. They are being, in some cases, uh, really coerced into that. But I think then when we look at what that looks like for patients, like you said, needing more complex care, it is absolutely a concern where if we don't have a properly resourced public hospital system, the patients who, and it's not just lower income patients, it's going to be everyone who needs more complex care is going to lose out if the system cannot deliver. But I do think the direction of travel is trying to increase and entrench a for-profit sector where once they have you in the door, there are opportunities to use coercion to get you to pay out of pocket. And that's what a lot of my research has shown over the last number of years is despite claims by governments of various stripes to say, oh, outsourcing is benign. It's just using public dollars. Patients don't care where their procedures are delivered. These are facilities, some of them, that have engaged in unlawful extra billing when they are also being contracted to perform publicly funded procedures. On top of that, we also have facilities and chains that are engaging in what they call out of province surgical care, where you're a patient coming from a different province paying entirely out of pocket to have that procedure performed for, $28,000 in that facility. And that's happening in Alberta too. So at the end of the day, it's about creating the environment and the context where you, as a patient, are really in a situation where there is a power imbalance and you are going to be asked or coerced into paying for things that you don't need to pay for in order to get the care that you need. And this is what's happening. And, it's, uh, it's something that's widespread in the United States. This is a model that has been this is a country with the most expensive per capita healthcare spending in the industrialized world, and yet has some of the worst outcomes when you look at a number of different indicators, including life expectancy and infant mortality and others. So these are not, is not a direction that we want to be going in.
Yeah. To me, if I was to sum up the whole thing, and then I'm going to give you the floor to add in anything else that you want to say. If I was to sum up the whole thing, it is tragic to me that it is not unrealistic to look at the whole popsicle situation and wonder behind closed doors were the UCP going, "Oh man, we messed that up. We took the popsicles away entirely. We should have charged 25 cents a piece." And that's not like to say that isn't ridiculous in this environment. To speculate, I'm not saying that happened, but to speculate that that's a conversation that conceivably could happen inside of the model that they're pursuing is not like it's not outlandish, it's not ridiculous, and it should be ridiculous to say in a public hospital there's the possibility that a kid who's getting cancer care or that somebody any other patient who's getting any kind of inpatient care would have to pay for those things. That's just bonkers. But given the conversation we've had today, I feel like it's also plausible.
Well, I think it's a philosophical view that can't, for some folks who are very focused on for-profit everything, they can't envision or don't want to envision a world where we actually do things out of compassion and shared commitment for each other as human beings. And I think this is what we're seeing play out so explicitly in the United States, where the idea that we do things for each other with no financial cost or barrier, but we do it collectively uh, as a commitment to each other's human worth and dignity is something that some of these folks are completely at the end of the day, I think they're just against that fundamental concept of sharing, of doing things for each other. And it means that things can't be monetized, they can't be commodified. And the worldview and the direction of travel in Alberta is that everything should be commodified and somebody should be able to exploit another person over it. And I think that is so fundamentally at odds with what has made Canada the country that it is. And I think that view of commodifying all of our social relationships with each other is something that's actually very much at odds with the vast, overwhelming majority of Canadians in this country. And I think we see this playing out with what's happening with the threat, the very real threat of annexation by the United States, where Canadians are saying overwhelmingly, I have no interest. I mean, even in Alberta, where you still see the vast majority of the population saying, I have no interest in this discussion of being annexed by the United States. Because I think we do have had this commitment to each other. And I think that's worth a lot. And I think it's absolutely worth fighting for. And I think we are at a moment of I think significant unity over what we share in common. And I grew up in the United States. I've seen growing up, how those inequities and divisions play out. And I don't think for a moment that's something that even the most ardent supporters of for-profit healthcare really want to see at the end of the day. The idea that you are at risk of personal bankruptcy because you get cancer and you have healthcare needs that are in the hundreds of thousands, if not millions of dollars, because it's at the whim of some private insurance company or some private for-profit hospital that determines what the price is. I don't think these are values that Albertans and Canadians share. And I think this government is very much at odds with where public opinion is. And as I've said, where the evidence is, their direction is not actually reducing wait times for the vast majority of procedures. It's not increasing surgical capacity. You're just enriching a handful of people. And I think it's becoming abundantly clear that that's the game. And that's what's happening. And it's not just in surgical care.
Yeah, I love what you said there because to me, if I was going to pick a core characteristic of Canadian identity, it's that we try to take care of our neighbors, whether it's our neighbors across the street, whether it's neighbors across borders. The Canadian ethos has been to strive to take care of everybody. I think this is one of the reasons why that Canada had the strong reputation for the period of time that it did for being the peacekeepers of the world and being leading the cutting edge of excellence when it came to those things. And it's bonkers to me that the same people who are lighting their hair on fire about the lack of a Canadian identity and how, oh, Justin Trudeau and his post-national state has destroyed the Canadian identity are acting in direct contradiction to what I think most people would say is a core defining characteristic of Canadian identity, where you just take care of people because it's the right thing to do. And it's bonkers to me that the hypocrisy is just it's breathtaking. Uh,
Hmm. Hmm.
Anything else? I want to give you the floor. Anything else you want to say? Anything else you want people to hear? Anything else you want people to do? It's yours.
I really appreciate the conversation, Nate. I would encourage folks, if they haven't had a chance, check out the report. It's at parklandinstitute.ca, both the 2023 report and the updated 2025 5-year analysis of the Alberta Surgical Initiative. And I think I'm going to be continuing to monitor the situation. And I think, it's really important for folks to talk to their friends, talk to their neighbors, raise these issues, have conversations. I think we can't allow the division that we see being encouraged by this government in particular to try to divide us. around our shared commitment to each other, I think we can't let that stand. And we have to actively fight that and work and engage with each other, as difficult as that might be. But to talk about, what does it mean to be using public tax dollars prudently? I mean, I think that's to me a shocking revelation through this whole thing is, um, you know, self-identified conservatives are not being prudent at all with public dollars. They're being very wasteful of public dollars, and I think that needs to be called out. So again, encourage folks to check out the report, and again, really appreciate the conversation, Nate.
Awesome. Thank you so much, sir.
And that's it for another episode of The Breakdown. As always, if you appreciate the kind of content that we're trying to produce here, we would love nothing more than if you thought about signing up to be one of our Patreon sponsors at www.patreon.com/thebreakdownab, where for just the price of a fancy cup of coffee a month, you can help us continue to produce this kind of content. Whether you're listening to the audio version of the podcast, in which case maybe leave a review and a rating, or whether you're watching it on one of our streaming platforms, we want to say a big thank you to everybody who is part of the Breakdown's audience. And as always, take care of each other and keep the conversation going.